Kia ora koutou katoa. Ko Waitinai, ko Ngāti Kahungunu te iwi, ko Ngai te Apatu te hapu, ko Tāki Tumu te waka, ko Tāki Tumu te marae, ko Wairoa Hōpupu ho Ningi Matangirau te awa, ko Bryn Jones tōku ingoa. I'm one of the chief advisors in the strategy and policy team now at the Ministry of Health, and I feel somewhat shy coming up to present to you guys, and after having had really authentic and meaningful patient stories or consumer stories, or whatever we want to call them, but real people in the room talking to us about their experiences of a different service and what a difference that's made to their healthcare. So I think it's really important to acknowledge that, and to acknowledge korowai. Now, I get this wrong all the time because I keep thinking he korowai oranga, which is our Maori health strategy from the ministry. But korowai aroha, for that leadership and bringing some patients along, bringing some real people to make this a real story for us all here who work in health and often see things from the other side of the fence. So now, as you'll see, the topic that I've been given to talk on, that I'm written down here is going to be talking about, is cardiovascular disease health target achieved, now what? And I looked at that when I was preparing for this, and I thought, oh, that's probably not quite what I want to talk about. So I sent Kim an email, and I looked back at the email yesterday, and it said that I was going to be talking about a forward-looking, this is my words here, a forward-looking strategic policy perspective on what's been achieved with the target, and how to keep a focus on cardiovascular disease, how to keep a focus on cardiovascular health and disease prevention. So that's pretty exciting, eh? And I thought, so as I was reading that last night, I thought, I'm not talking about that either. So I've decided to speak on an entirely different topic, but I think it's important to acknowledge a lot of the commonalities with our tobacco discussions this morning. If we approach this as, oh, here's what we do for tobacco, here's what we do for cardiovascular disease, here's what we do for obesity, we're going to fail. So I think it's really important to acknowledge the commonalities of the work we're all doing, and how that all needs to be linked up, and it needs to work for patients, and it particularly needs to work for those patients who it never works for. Okay, so that's the sort of intro to my talk. I mean, some of the things in the tobacco talks that struck me as that we have technology that is available to us that we don't always use, that we can use to better deliver population health stuff. There's a lot of ad hoc activity which can be streamlined if we have our processes better. Systems can automate what can be done without needing individuals doing things over and over in a not very useful way, because I mean there's no point in me sitting here giving patient after patient. So I work as a GP some of the time, but there's no point in me sitting there giving the same recorded message to people. That's not good use of that interaction. We want those interactions to be valuable, and we don't want people doing things that can be done in more efficient ways. So there's a lot of commonalities, and the tobacco and cardiovascular disease targets have really changed some of the ways in which we do things in general practice, and I think have given us an opportunity to think more from a population health perspective. So one of the big aha moments for me in this morning's stuff was this thinking that actually we need to be authentically and consistently committed to meeting people's needs, whatever their needs are, the person in front of us, rather than saying this is how we do it, and so we'll go ahead and do it that way, and if it doesn't work for you, we'll see if we can sort of add something on and make it a little bit better in some other way with some targeted interventions or something. What I'm going to do, instead of having any slides today, I haven't got slides not because I was too lazy to do slides. That's not the whole reason. So the reason is that I thought if I do a bunch of slides, I'll be just talking to you guys about my view of things and the ministry view of things. And I think we're really what I'm interested in is having you guys thinking about how can I do things differently in my work, but also particularly into the afternoon, thinking about that for the obesity stuff. You know, we have an opportunity with what is a relatively new piece of work in our obesity work through the ministry. We have an opportunity to make sure that is genuinely underpinned by an equity focus and that it genuinely delivers for Māori and Pacific and deprived populations, all of those populations who we know miss out mostly. So to be thinking about some of these concepts as we work through the rest of the afternoon is kind of what I was hoping for. So starting with that, there's I'm going to give some references to Kim or Fraser or someone to put up on the Heart Foundation website, which are articles that I think are useful, will be much more useful for you than any slides that I prepare and stick up on the wall. So just a couple of articles that I think have informed a bit of my thinking behind what I'm talking about today, and that I think are really useful for us to be thinking in terms of systems. How do we make sure our systems deliver better for Māori and Pacific, for deprived populations? How do we make sure that it works for everyone, not just for some New Zealanders? So that's a bit of a plug for the New Zealand Health Strategy, which is all New Zealanders. So, so there's an article that I've read recently, because it's a recent article, and it's written came from fellows at the IHI, and for me is framing out what I think is the important part of this discussion, which is building care that meets everybody's needs. So Lederman is the name of the person who this quote is from, and it says, there is growing evidence that suggests that disparities will be reduced and equity achieved only when interventions are tailored to the specific contexts and conditions that disadvantaged populations experience. So that's to me a really clear description that we need to be thinking, what are the important things in people's lives, and how do we know that if we don't know what people's lives are like? So we need the right people at the table making those decisions. We need people who know, we often have a room full of people making decisions whose lives look nothing like the people who they're making decisions for. So we need to be deliberate about that. We need to recognise that if we make decisions, we will make decisions that benefit people who are more like us, unless we are really deliberate about ensuring that we look after everybody. And I think that's what I understand from patient-centred care as well. Patient-centred care for me fits very well with the quality. So this Institute of Medicine did crossing the quality chasm, acknowledging that actually there's a big gap in our quality landscape in medicine. This was back in 2001, and they described patient-centred care as providing care that's respectful of and responsive to individual patient preferences and needs and values, ensuring that patient values guide all clinical decisions. So that's often not what we're talking about when I hear people talking about patient-centred care. So that, to me, describes what people are often talking about with cultural competence, that we're providing a service that meets everyone's needs rather than just people who are like me. And I think it's reflected in our system design. Our systems are designed to meet the needs of people like us first. And that, I mean, even when you look at, from John's talk this morning, about the prevalence of smoking for Māori and Pacific, and I don't think we saw a slide for non-Māori, non-Pacific, but the relatively high prevalence of smoking for Māori and Pacific compared to non-Māori and non-Pacific. And yet when we looked at GP visits about this, there was the opposite pattern, whereby 80% of the total population had visits with their general practitioner about smoking, 73% Māori, 76% Pacific, so it's the opposite. It's the inverse care law that we're seeing there, which is saying that we deliver more of our care to where it's needed least, and that's not good use of our resources, and it's not equitable, it's not fair. So that's my real place, and I guess that what I'm interested in would be to think if we're thinking about how do we design things in a way that they are genuinely underpinned by equity. We have got resources for that. So the ministry has a what's it called? It's called I call it the equity framework. It's called Equity of Healthcare for Māori a framework, is what it's on the website. But if you look up the equity framework on the Ministry of Health webpage, it's got some tools there for saying this is what we can do to ensure that actually all of the services and things we're designing will meet the needs better for the population groups that miss out. So that's one of many tools. I mean, it's similar to I'm sure many of you are familiar with the health equity assessment tool, which asks similar questions about our population. Who's going to benefit from this in our population? Who's going to miss out? What is the impact on equity and so forth? So if we've got a quality approach to things, we need to actually have a quality approach which underpins all of our population, not just those who are easy for us to reach. And so in terms of what does that mean going forwards, if we don't have a deliberate focus for instance, if we don't have a deliberate focus on Maori men and cardiovascular health moving forwards, we will not be targeting our resources appropriately. Okay, if we just keep focusing on meeting the needs of everyone, and we'll reach a total population target as being our aspiration, we will see that just about everywhere in the country we have lower rates of cardiovascular risk assessment for Māori as opposed to non-Māori.
Can I just say that title kind of irritates me as far as have we reached the health target for Māori? No, we haven't.
Yeah.
So, it's like how, the ministry we're talking about equity, but actually it's not even going to be in IPIP next year, and we haven't met the target for Māori and Pacific.
Yep. So one of the things is we haven't met the target for all population groups, and we haven't met the target in all DHBs, and I think that those are quality issues, and I think that is reflective of not of us not thinking that's important, but of us not having an approach which was genuinely underpinned by a focus on those population groups from the outset. So I think that's a learning in that. We know that we've got lower rates just about everywhere in the country for Māori men, or for Māori compared to non-Māori in terms of cardiovascular risk assessment. So it's absolutely correct. But what I just wonder if at your tables, if you think about just have a quick discussion at your tables about what you might do if there's an important piece of work that you're doing. What equity considerations have underpinned that work? Have we thought about what the intervention is? Are we looking at something where there is a health equity issue that's important to address? Are we doing it in a way that targets the people who most need that intervention? All those kind of things. But just have a think about either a project that's on one of your plates now, or that is something that you've done recently and you've either struggled with or you've had some successes, and I'm sure there'll be someone at every table who can have an example to talk about. So do you want to just do that for a few minutes now? 5 minutes? Fraser's got all the useful information for you to talk about very shortly. Now, I asked Fraser if his talk was interesting, and he said, of course it is, it's maths. So I think, prepare to be riveted, you guys. But the thing that Fraser's going to talk through with you is in terms of, obviously, the target, the national health target for cardiovascular risk assessments is going to end as of the end of this quarter, which is next month, only just next month. So what's that going to mean in terms of our focus from a cardiovascular health perspective nationally? It's going to mean that we don't have national reporting of that particular target. And so the target that's going to replace it is the obesity target, which will essentially mean that we have the same number of national health targets, which has been the 6 health targets we've had for a long while now. So what I think is important is what does that mean for this push that we've had on cardiovascular risk assessment? And I think there's been growing desire to have a cardiovascular risk management target rather than an assessment target. And I think we also know that we need to think about secondary prevention. Once people have got established disease, what do we do to make sure that their risk of further events or their heart failure is managed well? How do we manage cardiovascular health for people who do have cardiovascular disease as well? So all of those things are important, and keeping our focus on those things is not going to be something we can do through a target, through a check. We've done that. We need to be thinking about the quality of those interventions as well. So if we're having a cardiovascular risk discussion with our patients, with our whānau, with our communities, we need to be talking about those things in a way they understand it, and that makes sense that makes sense regardless of how we measure cardiovascular risk. So if we change our risk equations, we still need people to understand the same messages that we're giving in the same way. So Fraser's going to talk to you about exactly how to do that, and I think the ministry's focus on cardiovascular health will continue to be through ordinary monitoring mechanisms that the ministry has with DHBs, so rather than having a particular target that's reported in the papers every 3 months, the next one will be the last one that the cardiovascular risk target's presented in the papers. So we do want to keep that focus on, and we're interested in particularly your guys' views about how to ensure that focus remains, particularly for Māori and Pacific, particularly for deprived populations. And I think any feedback you guys have got, I'm happy to receive feedback. I'll make sure that my email address is available via the website as well, if you want to get in touch with me. But we do have it. Cardiovascular health remains a big priority. It's a big cause of death in New Zealand, and it will be even with the massive reductions we've seen in the last 10 years. So thank you very much, and welcome, Fraser.